All right, good morning, everyone. I'm Valeria Gall. I'm the project lead with the BC Centre for Excellence in HIV/AIDS. We're here today for the Interior Boost Collaborative Preparation webinar, and we are recording the session for educational purposes. If you have any concerns, let Angie know. It'll be posted on the website, so anybody that misses the session can view it at a later time. And if you like, in the meantime, you could also just type your name in the chat along with which team you're associated with, so we can get familiar with everyone as they join. Right, so I'd like to start off by acknowledging that the land on which we gather is the traditional, ancestral, unceded, and occupied homelands of the Coast Salish peoples, including the 7 Interior Region First Nations where we live, learn, collaborate, and work together. This region is also home to 15 chartered Métis communities. It is with humility that we continue to strengthen our relationships with First Nation, Métis, and Inuit people across the interior and BC. We also want to acknowledge that others may be joining from different traditional homelands today. This acknowledgement is a reminder of the discriminatory, racist, and colonial practices that have had a lasting legacy and continue to create barriers for Indigenous people in the healthcare system. I want to thank our sponsors and funders that are making this possible for us to do the Interior Boost Collaborative, and that's Health Canada Substance Use and Addiction Program, Shared Care, BC Centre for Excellence in HIV/AIDS, Interior Health, and all of our funders and partners, including client partners and family voices. So just a quick reminder of the Zoom control panel. I want this session to be more of a dialogue and conversation as we go through the different pieces that we want to cover. So I'm more than happy to have people raise your hand if you have questions during the presentation, or if you want to type something in the chat, we can pause and talk about it. The idea of this webinar today is really to make you familiar with the different resources and supports available to ensure that we answer any questions you have. So please don't hesitate to just raise your hand and ask questions throughout the morning. So our focus for today is to just dive in a little bit more into an overview of what Boost will look like, and just talk about the different resources. We're going to just give you a bit of a tutorial of the reporting platform, as well as the Interior Health EMR reports that Andrew will go through. There were some questions around that before. And then we're hoping to have some time at the end to continue the work around the aim statements that we started at the session last week. All right, so I'm going to try and find a new image for this so that you don't get bored of looking at the same one, but I wanted to just spend a minute or so just having everyone use an annotation marker to note down where you're from, just to help us all feel connected virtually, given that we're not able to be in person yet. So we've got Kelowna, Vancouver, Armstrong, Lake Country, Kamloops, Nelson. Great, so we've got people from all over the region, which is great to see. And I think we have a few other teams that may be joining from other parts. So it's nice to see where everyone's located. I'm actually going to the Okanagan for the first time this summer. I don't know why we haven't gone, but my daughter came home from school saying, why does everyone in my class go to Osoyoos? What is Osoyoos? Can we go? So we booked it, and we're excited to explore your area. All right, so just to remind everyone of the focus of Boost work, there's a number of things that lead to why we're in this crisis, and things that can be done to support, ending the crisis and changing what we're seeing. Unfortunately, we can't focus on everything, so we just want to reiterate that what we're focusing on is expanding and improving OAT treatment, and that is the focus. We don't want that to stop conversations around any of the other items. We just want to make sure that we're aware of what we are able to focus on now. And through this work, we do hope to be able to address some of those other pieces indirectly. So here we're just reviewing again our timeline or our structure that we're using for this work. This is developed from the Institute for Healthcare Improvement, and it really follows a series of learning events followed by action period in between, where it gives teams the opportunity to apply the learning, where they're going to be supported with coaching and webinars and coaching calls and all these other pieces here that are intended to just really help the teams move the work along. And then the big picture of that is really looking at sort of the three phases of a collaborative, where we start off by preparing and understanding the gap in care, and then actually diving into the collaborative activities. And then the end goal is really to develop and form this community of practice that supports the sustainability of the work. So maybe I'll just pause there for a sec to see if there's any questions or comments about any of that. Let's look at the chat here. Don't see anything in the chat. Okay. Again, feel free to jump in with questions or comments during the session. So this is the aim of Boost. This was something that we reviewed with a group of individuals from the interior region for a planning meeting we had a couple months back. And it is very similar to the same aim statement we had for the Vancouver Boost back in 2017, and then the provincial Boost in 2019. We've made a few tweaks along the way, but the consensus was that we were all agreeing that this was going to be the focus for the Interior Boost Collaborative. So as your teams look at developing your aim statements, think about these sort of big overarching goals, but also think about what's important and needed in your own local setting, because we recognize that'll vary from site to site. And then again, we're here to support and work with you as you develop that statement to ensure it aligns to this larger aim statement. What we'll also do at some point is dive in a little bit more into our driver diagram, probably at the next session. But essentially what this is these are the different drivers that have been identified as supporting us in reaching that overarching aim. And so there'll be a change package document that will be circulated, and that'll have a number of change ideas, mainly under these 5 buckets. That doesn't limit us, excuse me, from looking at other items as well, but this just gives you a sense of some of the ideas that were used before. So I'll just leave it up here for a sec while I take a sip of water. Sorry about that. Any questions around this driver diagram? Cole, Andrew, anything you want to add to it? Nope. All right, I'll move us along. These here are the core measures that we've identified in supporting us in working towards those 3 aims. And so this outlines the numerator, the denominator, and the target. And this really is what we'll be looking at in those monthly reports, along with other information. So what I'm going to do is just jump into the reporting platform and give you a walk through what that looks like. Give me one sec to switch screens here. Okay, so you'll get a login link along with a username and password. Each team will have their own, and we'll send that to the team, the person identified as the team lead at each site. You guys can decide how you want to manage that in terms of assigning one person to be responsible for that or sharing that. That's really up to yourselves. All right, so when you log in, I'm using the test site, so it might look slightly different, but essentially I'm selecting a site. In your case, you won't have that option because it'll just automatically go to your site. On the back end, we're able to select a site, and we have a list of all the teams. And so we can go in and look at each team's report. So from there, you'd go into team reporting. And the first section is just looking to see how many times your team met during the reporting period. And from those meetings, how many involved a QI coach. And it's really just to ensure that each team is meeting regularly, receiving the support from the QI coach, and if they're not, then we can try and support the team and try and ensure that they have the time to do those meetings and to do this work. The next one is looking at changes and improvement activities. So here, what you'll do is you will list any change ideas you tested. So for example, if you tried reminder calls as your test of change this month, you'll describe that here or list what it was. And then, you know, how many times did you revise that PDSA cycle? So you could just put, you know, reminder calls to clients before appointment or before script runs out, and then you can just say you tried maybe say 3 different cycles, and then if you decided whatever you tried was working, then you can click adopted. If you decided that change didn't work, then you can just leave that blank. And this here is what actually really helps us in hearing what each team's doing and generating ideas and then sharing them with other teams. Often we'll see on these reports that, you know, a team is reporting they've done really well with this area and they've been successful in making this change. And then from another team, we'll hear that they're struggling with that particular area. So it allows us to spread and share learnings. And of course, we encourage teams to do that, but it also lets us facilitate that. And then the next question here is looking at considering the changes listed in the question above. Please complete the following fields to plan sustainability and spread activities. So this is something we're going to look at later on towards the second half of the collaborative, but don't hesitate to check off things that have supported you with that change. So for example, if the change around that involved you now having that part of staff orientation and training, you can click that. You know, if there's, you know, an SOP or some sort of documentation that will ensure that this process is clearly outlined for others to be aware of, you could check that off. But this is not something you need to worry too much about in the first few months, because we recognize teams will be going through these tests of change a few times before they get to a place of adopting an idea. And then here you could also share, you know, an attachment if you have, you know, an SOP or some sort of document that you're willing to share, then that allows us to also share it with the broader collaborative. And then the next question here is looking at including the client and or family voice in your improvement work. And so we've got here this scale here that we've developed with different pieces of work that supports this, from having, you know, sort of small wins and easier things to be able to try and implement, to things that take a bit more effort and require more support. So as you start to click these different things, it moves up the scale, and that gives you a sense of, you know, where you are in a kind of achieving that end goal of having a client or peer embedded in your team. And I do believe that we're working on a webinar for next month around this topic. So we'll be able to share some ideas and supports that can support you with that. And then here, there's just a few free text boxes around any accomplishments, challenges that you've had during that reporting period, and any extra supports that you need here. I'm just going to move into the last one, which is the quantitative data. So here we're looking at the core measures. So we want to know how many clients diagnosed with OUD and receiving OUD care from your team, and that's your population of focus. And the reason we say receiving OUD care from your team is that there may be clients with OUD, but they're coming to your clinic for something else and they're not getting their OUD care. So you wouldn't want to necessarily count them in there, because you're not involved in their OAT treatment. But again, that's something your team can discuss. And if you think that you do want to include it, that's totally fine too. Then we break it down here. Again, these are some of the things that Health Canada really looks at for our reporting. So these are just really measures that we want to capture over the course of the collaborative. And then looking at our project aims, how many clients have an active prescription, how many have been at your clinic for more than 3 months, and then how many are retained on OAT for more than 3 months. And then it'll automatically create percentages here once you enter in these numbers. Cole, did you want to add anything further here on the metrics? No?
No, I think you covered it all.
Okay. Yeah, and I think this question here that says clients that have been at your clinic for longer than 3 months is that, you know, if they just started, they wouldn't be part of this pool, right? If they've just been put on OAT and it's less than 3 months, we want to ensure that to look at retention over 3 months, they've been with your team for more than 3 months. But again, your team may have slightly different definitions of some of these. So, you know, certainly reach out to us and we can work through those. And we want to ensure you're reporting what's meaningful to your team as well. And that's it really. Then you would just hit save. And then I believe there's a submit button as well. So you can add information, save it, and then submit at a later time when you're ready to submit. Is that right, Angie? Yeah. Okay.
Yeah.
Any questions or comments about any of this? The next part, Andrew's going to talk about the reports that you guys have in Interior that'll help get this information. But any questions or comments about any of this so far? So Angie's just mentioned you can hit save in the top and come back to it later. So reports will be due on the 1st of the month there around. When there's a weekend or holiday, we'll adjust that. And then you will get a reminder if you haven't submitted. And we recognize, you know, some months are busier than others and you may not have time for all this work. So feel free to just fill in what you can. You know, if the only thing you can report on this month is the challenges you faced, you know, even just around doing this work, please by all means fill that in so that we get a sense of what's happening on the ground. The last thing I'll show you is, I believe it's under, where's the, where they put the aim statement again, Angie?
Yeah, so if you go to administration, click site maintenance.
Okay, here we go. Yeah. So this is where you would have probably the team lead's name here, their contact info. And this is where we want you to submit your aim statement. Again, this can be edited over time and you can update it along the way, but this is what you can enter in for the first reporting period. That's what we're really looking for, is to have at least that piece submitted. And then again, you hit save and then that's done. And then, like I said, anytime you can come back to it and update it and revise as needed. So that's all for the reporting. I'm going to, I think, hand it over to you, Andrew. Are you good to go through the reports for Interior?
Yes, let's do it.
Okay, let me stop sharing. And I think you are a co-host.
Yeah, thank you very much. And I just want to say thanks to everyone. We have 7 teams represented. Oh, my mirror's reversed. 7 teams represented here today. So great work, everyone, coming out. All right, so the first thing that I would like to share, most of you have seen this. This is the profile EMR, and this is what the OAT encounter form looks like. So for prescribers, when you're writing a prescription within profile, these are the fields. Those of you who are prescribers, you probably know this field really well, or this form really well. And one of the important things for looking at our measures of you know, active prescriptions and prescriptions over time is this prescription type field right here. So, you know, most of the other fields should be pretty self-explanatory. This prescription type field, by default, knowing that many appointments are just routine appointments where it's like a stable patient where there isn't a change in their dose, the default value for this field is dose unchanged. But for us, knowing that for that one measure, we're looking for people who have an active prescription with no restarts in the last 3 months. If you did have a restart with somebody, just want to ask you to remember this field and tick on restart there, because what that does is that resets the counter back to 0. And the same as a new start. If somebody had, you know, gone off treatment for a little while and they've come back after a period or whatever, and you're considering that or a new start again, then just make sure you're selecting that there. And so what that feeds into, and I also recognize too that, you know, we asked a lot of teams in filling out this form, and it took a while for us to develop the reporting form so that you can actually have access to some of your data to use for purposes like this. And so I'm going to start right at the very beginning here. So for Interior Health, the Insight reporting platform is what we use to see many reports. And so I'm just going to go right from the very beginning. So I'm at our InsideNet page, and I'm going to do a search for Insight. Many of you are already familiar with this, managers for sure. You might have it bookmarked already. Your Insight screen might look slightly different than mine. It's just based on whatever access that you have. Many of you are used to coming in here to look at the QSB, the Quality Standards Board, for the MRR for all the MHSU clinicians. And what we're going to do is we're going to look for this folder called Primary Healthcare. And Primary Healthcare, this is all the reports that are related to profile. So I clicked on that. It opens up a folder here. And then you can see these are a number of reports that are available for any person who has access to profile. So you can look through some of these. If you offer time in evenings or weekends, there's a report that pulls evening and weekend appointments. What we're going to look for is the OAT improvement dashboard. You double click on that. The POS, we all know the POS, the place of service. That's the location within profile. And lots of teams here, and it lists all the profile locations. Everybody has access to each other's locations. So if you're in Salmon Arm, Janet, and you want to look down the street to see how Vernon is doing, you can plug in Vernon or wherever. Does anyone want to see their community on here for our little demo?
Sure. Mine's 10th Street Clinic at the top. Yeah.
Awesome. Thank you. So I'm selecting 10th Street Clinic over here. And then the as of date, this is the report run date. So if I put in today's date, this is going to run everything as of today. I'm going to choose May 31st of last month. So the last day of the previous month. We wait a few seconds. The larger clinics like Kelowna with 1,000 patients will take a little bit longer for the report to run. All right, so here we go. If you're interested in reading all the background data, you can do that. And then we see some of our information. So when Valeria was talking about the reports, so the asking for the genders, we can see that right at the beginning here. So 64 males, 29 females. While Boost isn't asking for an age distribution, it's provided here. The provider stats, these are kind of clinic stats. So this shows appointments that were booked each day, number of patients arrived. That row actually isn't working. I've put in a request to IMIT to fix that up. So if the MOAs in your clinic are arriving people, so if there's an appointment booked, one of the features in profile is arriving the patient. So when they show up, you arrive them, they show up in the little waiting room in profile. Same with no-shows. If the MOA is selecting no-shows for people who don't make it to their appointment, you can enter that there. And as well, it's looking for new starts and restarts. So at a glance, you can see, you can get your week in review to see some of those very basic stats. Lots of people are interested in like virtual care these days. So as long in the appointment booking, as long as you're choosing if it's an in-person visit or a virtual visit, then those will be reflected here. And then here are the measures that Valeria was talking about. So patients with open referrals, this is the population of focus fund. So with all of our clinics being dedicated OAT clinics, everyone who's coming into the clinic presumably is somebody with the opioid use disorder. Valeria, you made a good point there too. If there was somebody in the clinic who was just receiving primary care, they would be reflected. A team would have to manually do that calculation if they knew there was a couple or more patients in their clinic that weren't a person with opioid use disorder. And then directly below that, patients with an active prescription. So this is looking to the date that the report is run. So for May 31st at the 10th Street Clinic in Castlegar, 32 of the 93 patients had an active prescription. And then within there, 18 of the patients had active prescription, meaning no restarts within the last 3 months. It shows a number of patients with an expired prescription. And then the patients with no prescriptions, it's almost like an error report in some way. So what the report developers have told me is, so this could be somebody where they're registered to the clinic, but there isn't a prescription that's in profile. So it could be the case of somebody who hasn't been able to make it into the clinic, and the prescriber is doing like handwritten prescription forms and it's not being logged in profile. There may be a few cases of there's some sort of registration error that's causing the report to not pull it correctly. So I'll tell you, but I won't show you because it has actual patient names, but some of the other tabs at the bottom show lists of patients with expired prescriptions. So you'd be able to go through and do a little bit of sleuthing or troubleshooting for patients who are registered to your clinic. Over on the next tab, OAT Encounter Dashboard, it provides some basic information, again, based on the patient. So the basic gender breakdown, the age breakdown. I recognize one of the limitations of the EMR systems that we use is that they suck at capturing gender. They capture male and female, and definitely do not do a good job of capturing other people's genders in here. If you're interested in the treatment breakdown, that's listed here as well as the age distribution, and then the communities where people live. So Castlegar surrounded by lots of smaller communities there. You can see that the majority of your patients are from Castlegar, and then the rest are from the surrounding areas. And then of course, there's always like, somebody who has an address of like Vancouver or Calgary or Quesnel or Surrey or something like that. And that's just somebody's address that needs to be updated in profile. The run chart is a super valuable tool for me, especially. I'm a real visual person. So I really like the run chart because it kind of gives you, it gives you a look at how things have changed over time in your clinic. So with the 3 measures that we're looking for, we have the blue line across the top. This is open referrals. In the Boost language, this is our population of focus. So we can see for Castlegar, it's a fairly flat line up there. And then for active prescriptions, we see a big steep line. This is probably around the time that the clinic started to use profile. So we see a big sharp increase in the number of prescriptions in profile, and then a fairly flat curve there. And then the active prescriptions 90 plus days. These are the number of patients where they've had active prescription, but no restarts in the last 3 months. So we see that climbed a little bit slower, and then has remained unchanged for a number of months. And this is really great too. So as you start doing your tests of change and trying out your new initiatives, this is where you're going to potentially see the impact of those changes. Whether that's something went way up or something went way down. I remember a great example a couple of years ago. There was a shortage of Cadian, so a number of people, that was like quite destabilizing for a number of people. So the run charts at the time, they kind of showed that active prescriptions kind of dropped off, and by extension the 3 month measure also dropped off for a period of time while there was that disruption for people who are taking Cadian. And the run charts, like, it's easy for me to sit here and provide some very brief analysis for the Castlegar OAT clinic here. But Becky, you and Dr. Van Vliet, you guys know what happened. You guys know what's happening in your clinic. So the results are most meaningful to your clinic. So what has happened on all these months. What's happened in your clinic. you know what's been going on there, and you can probably, you know, interpret this and be able to pinpoint, oh, that month, that's when this happened, or there was a staffing change, or
I think something's wrong with the data because we have almost essentially everyone's on an active prescription right now. So there must be something with the way that we're doing it that it's not coming up right. Because out of 93, I think we have like 87 people on active prescriptions. So something has happened.
Yeah,
Perfect.
so I was waiting for you to say that because I think for the vast majority of teams, initially you'll feel this is wrong, right? And that's why we do this initial phase of understanding the population of focus and how the report arrives at that. And then it usually requires some data cleanup. So maybe you have some old referrals that need closing, or people being missed, or it'll just require a bit of a drill down with the person who knows how your team is entering things in the EMR, but also understands how the report is capturing it from the EMR. And that's okay. That's part of the initial QI process. So this is a great example to go over, because I think most teams should expect to at least do a bit of cleanup in order to really understand and trust the data they're seeing. The other thing is, Andrew, you mentioned you can see other teams' performance, but just like what my Peloton instructor reminded me this morning, it's more important to compare yourself yesterday to today than to compare to other teams in QI. So remember that. And, you know, even if your numbers aren't nearly as great as other people's, it's more about the improvement over time that we're focused on.
thanks, Cole. And Becky, I see you adamantly saying that this report is wrong. And one of the reasons why this report took a really long time to create is because because we kind of, you know, the programmers who created that OAT form, there's a lot of complex work that happens behind the scenes in the database. And so even more complicated when they come to this reporting platform. So I invite you and other people from the teams, you know, take a look at this report, and if you see something that doesn't portray what you think is happening in your clinic, I ask you to be specific. So I won't click on these other things. So patient panel by provider, these are patient lists by provider. Patients with expired prescriptions, I won't click on that one, but that's a list that shows people. So I ran this as of May 31st. So this would show anybody as of May 31st with an expired prescription. So if you can provide feedback about specific patients, so if you're saying you have about 87 patients, try to identify who are the 20 patients that this report isn't picking up. And then as Cole mentioned, it could be something simple in profile that just one thing isn't being ticked or something like that, or it could be that this report is not pulling things the way that it should be. So if you can provide specific patient examples when giving the feedback, that'll help make this report more valuable for everybody.
And Andrew, would teams have the opportunity to have like a one-on-one meeting with like the QI coach and potentially somebody from IMITS who understands the report?
Yeah, that's a fabulous idea.
There was also a question from Tammy in the chat about patients on safe alternatives and whether this will be captured anywhere.
Yeah, thank you. That's a question that's been asked for a long time. So yes, it's in the plans to, I don't know if they're just going to add the additional medications, the hydromorphone tablets, and a couple of clinics are about to start doing fentanyl patches. I don't know if they're just going to add those medications to the existing OAT form, or if they're going to create a separate form for those medications. I don't know exactly what their plan is yet, but it's definitely on the list. can't give you the timeline for those yet. And fully for those prescribers who are doing the hydromorphone tablets, know that it's a royal pain in the butt and takes a lot of time to write out all those prescriptions.
So maybe a question back to the group on that. You know, in terms of our primary outcome being retention on OAT, what do you think? Would we include the hydromorphone safe supply?
I would definitely like to see that. Here,
So-
actually, I'm gonna go to Alicia's computer.
Rebecca, were you gonna?
I was just gonna say, it can be a helpful way to help people stay on OAT, like the whole carrot idea. So maybe that's not our exact focus, but it's definitely a factor.
Yeah, I think, you know, getting people up to a therapeutic level has been, I think the addition of hydromorphone has been a great addition for that purpose.
Well, my question, I guess, will it change our numbers? Are we double reporting on those individuals if they get the hydromorphone plus the Cadian or methadone?
Yeah, good question. So yeah, I agree with what everybody has said here. And so it sounds to me like hydromorphone, the safe supply, has become part of your process for getting people on OAT and retaining them on OAT. That being said, would you consider it as OAT itself? Like if somebody was just on hydromorphone, would you say they're on OAT? No, right? So I think, you know, it would be good to have the measure of number of people with safe supply, but I think it's probably a separate measure, right? It's not the outcome measure. It's maybe a process measure that we look at. And I know we look at it at our clinic and see that now we have the majority of people on both. So there's that. And yeah, so if you counted just the people on safe supply, then that's kind of saying, oh, so we've got success for that client, and maybe prematurely stopping trying to move them on to a long acting or an OAT.
And an interesting experience. So one of the other things I've been supporting is there's a safe supply clinic that started up in Penticton that's partnered with the South Okanagan Division of Family Practice. A couple of the, if you know Penticton, it's some of the Martin Street group of providers. They've partnered with Penticton MHSU to identify people who are at high risk of overdose, to start them on safe supply, and they're primarily using the hydromorphone tablets. And they have about 43 patients already. They filled up really, really quickly. And I think 39 of the 43 are on OAT, like they're on Cadian primarily. So it's, you know, for the providers, you know, for them and for many prescribers in Penticton, they're still pretty leery even about hydromorphone tablets. So the OAT, they really see as, you know, that's their main goal, to get people on that OAT. And they're finding, just like you said, Tammy, like the person came in, you know, getting the safe supply, but then also getting the Cadian or the methadone or whatever, plus the additional support from the MHSU clinicians, that they're already seeing some really, really great results of people that they've, you know, really struggled with in the community, people who've, you know, really struggled to be and stay on OAT in the community, and people who, you know, who are at super high risk, people with multiple overdoses, multiple hospitalizations because of substance use, you know, kind of on the radar of the community of, you know, on the various lists, you know, whether that's, you know, known to bylaws or police or any number of people of concern in the community. And already just in the last about 6 to 8 weeks, so many of those people, there's like great success stories of people being retained, people, you know, wanting to volunteer, wanting to do peer support, and more importantly, picking up their medications from the pharmacy every day. So like, I really love this discussion about, you know, OAT versus safe supply. And I think for many of the examples that we see in interior health, you know, OAT continues to be the really important thing that protects people from overdose death. And like you say, Tammy and Becky, like the hydromorphone tablets is like this really awesome test of change that our province has been doing to help retain people on OAT.
Right, so one of your team's first change ideas might be something around changing your process for offering safe supply, or checking that people have it or still have it. Because the theory of change is if you do more of that, you're more likely to keep people on OAT. Andrew, I remember you mentioned the fentanyl patch as well. Same question for that. Would you consider that OAT, yes or no? And then would that be important right now to include in our outcome measures? And that's a question for anybody in the group.
Sorry, Cole, could you repeat the question? I was completely distracted.
Oh, that's all right. So fentanyl patch is kind of up and coming. Maybe some of your clinics will be starting to offer it. I'm wondering, would that then be considered a form of OAT? And then is that, if it is that important to include in our outcome measures?
And I think we'd be putting Jen Glenn on the spot, because she's Vernon and Kelowna are currently the only communities that are going to be doing fentanyl patches. And Jen says she sees it the same as other forms.
Yeah, I see it very similarly as the other forms. So I was kind of move over to this other computer just because of the feedback. But I see it very similarly as the other forms of safe supply. You know, our strategy when we roll out the prescribed safer supply of the fentanyl patches is really going to be to embed it in our current OAT clinic. But I hope to move forward to just offering pure safe supply. It's just really at this point a physician capacity issue for us. But, you know, I think the physicians really need to be the leader of that discussion, because the physicians are the one who tend to want to really encourage the OAT and steer away from prescribing safe supply on its own. So I think that's really good dialogue and really good conversation. But I think it's too early to say in terms of the fentanyl patches. But I at this point, I see it very similarly as the Dilaudid. Is this going to increase, you know, client retention to our clinics and to the supports that they're receiving? Is it, you know, are they getting the same outcomes, positive outcomes that they get from OAT? Right? Is there increased retention in housing, decreased criminal activity? All of those things are things I would like to see similarly with any OAT treatment.
All right, any other thoughts around that?
Not specifically to that, but just kind of on the same train of thought is just MS lawn. You know, kind of see it as more, I don't know, like I know it's listed under sort of safe alternatives, but it seems to be more under the OAT in terms of being used in rather than Cadian on some occasions. So
right.
It would be good if some of that was maybe collected, or what people's thoughts are on that.
Yeah, so that's a great example. And some of those are kind of in between, right? And some people may be using it more as safe supply, others more, they're taking it regularly and it's more like OAT. The good thing is in QI, we don't need the perfect data, and it's usually a small percentage of our panel who are doing these sorts of things. So we can say, yeah, we know it's happening, but we know it's small enough numbers that it's not going to really affect our QI measures and our outcomes. So we say that's fine. I mean, for the fentanyl patch for our clinic, I think we're seeing some people where they're on it really regularly. They're not using other opioids now. So I picture it as a form of OAT, and we're getting to the numbers in our clinic now where I'm like, oh, maybe we should start including this in our QI measures. But luckily for your clinics, if you're just getting started out, it's going to be small numbers initially. So at least in terms of the measurement, it's not yet important.
And then while we're talking about all the many medication options, I know that Sublocade has also become quite common in lots of interior health clinics. And the last I checked, there's a few hundred patients across interior health who are taking that. And that's a medication that currently is not in the OAT list. And I think, and Cole, I'd be interested to, knowing that it's like a monthly cycle. So the retention measures, how's your clinic capturing the Sublocade retention?
Well, yeah, and that's interesting because we have way less. I think we maybe have 1 or 2 people out of hundreds on it. It's a bit of a different makeup in the downtown east side, less Suboxone, less Sublocade. But yeah, maybe that's the opposite. It's probably more important for your teams to have that included.
I'm gonna just jump in and move us along so that we can wrap up in time. But this was a great conversation. And again, these are things that you're welcome to put out on the listserv and have a broader conversation with other people about it as well. And we can certainly ensure we include time at the next session to have more of this type of dialogue. All right, so I'm just going to quickly go through a few more things. So just a reminder, our email listserv is this email address, boostcollaborative@stophivaids.bc.ca. So whenever you get those reminder emails from myself, I'm sending an email to this address and it goes out to everybody on the listserv. So feel free to use that for anything that you think would be helpful to discuss with the wider group. If you're looking to get in touch with just our team directly, the email for that is boostcollaborative@BC-CfE.ca. So just keep in mind that there's those 2 different email addresses for those 2 different purposes. We do have a QI coach that's joined our team officially. Her name's Kelsey. She's not on today, but we'll ensure to connect all the teams with her. And she will be supporting you with your regular QI meetings and coaching support. So stay tuned for more details on that. This is just a snapshot of our website. As you can see, we have different boost sections in there. There's the network section, the provincial boost, Vancouver boost, and we've got an interior boost section there now. So anytime we have these events, the recordings and PowerPoint will be uploaded and saved on there, usually within a couple weeks. And then you are welcome to go in and look at previous content from the Vancouver and provincial boost and the network as well. And we've got another initiative there on treatment optimization of psychosis using a similar framework. So everything we do is available on the website for anyone to look at it at their convenience. Just a reminder to take a few minutes to go through the prep resource manual that was sent out. It's got a table of contents that breaks everything down so you can go to specific sections. If you're interested in a hard copy of that manual, we're happy to mail one to you. Just get in touch with us and we can do that.
Andrew will sign the cover as well if you're interested.
And then I just want to remind everyone that, this is a lot that we're covering here and that, this is really an improvement ramp. We're starting with small steps and we're going through these, different cycles and working towards the changes that result in improvement. And so just be patient with the process, recognize that it's not going to happen overnight. And if it feels like everything's a little slow moving, it's supposed to feel that way. So just keep that in mind that you're really starting off with small steps towards that end result, which is why we're doing this over the course of 10 months. So I know we don't have a lot of time left here, and we did want to have some time to go through the aim statements. I also wanted just to take a moment for everyone to think about, what are the strengths of your clinic and team? And this was an exercise we did at the planning meeting. And so I wanted to share it so everyone can have a look. These are comments made by individuals from some of your teams. And I think it's important that we take a moment to look at, what are we really doing well at our site so that, this work isn't just focused on looking at how we can do better, because there are things that you guys are doing really great. So if you want to just take about 30 seconds to read through these or think to yourself, what is something that your team's doing really good at? You can write it down on a sticky note in front of you, or you can type it in the chat. And again, I just want to emphasize the importance of taking some time to think about, the good work that is happening that, doesn't need improvement before we shift our minds to that. So I think here a theme that really stands out for me is really meeting clients where they're at is something that's mentioned often, and that you guys have really hardworking teams that meet the client's needs. So I think, those are really, really important strengths that each team has that really make this work move forward. It's a reason why clients come back to your sites is, feeling that they are heard and that you're working with them. Yeah, I see a comment about the bears. I remember that actually. I don't see it here, but I remember there was a comment. Yes, above and beyond for people we are caring for, even in extreme conditions with bears. All right, so now as we go into sort of the next part of this, which is areas of improvement. So again, these are some of the things that came up at our planning meeting, and this is really just to kind of get your mind thinking of what are some things that your team wants to focus on. We recognize each site is different. So, what works in one area may not work well in another. So it really, really varies. So that's some of the points that were brought up. If you want to take a minute to think to yourself of some of the things that your team wants to focus on, feel free to write it on a sticky note in front of you or type it in the chat. And then we'll move into the aim statements for the last few minutes. So just to read some of these, housing is a big one that comes up a lot here. Outreach capacity, operating hours. Stigma, yeah, that's also something that I know continues. And burnout, yeah, those are some challenges. All right, so as we think of our aim statements, this was covered last time, so we want them to be specific, measurable, achievable, realistic, and timely. So we want to make sure that we have those 5 aspects to it. So what I have here is a few examples of past aim statements that were used for Boost. So the first one here was a team set a goal or an aim of by April 15th of 2019, 50% of the detox clients receiving OAT during detox will be linked to a local OAT clinic at discharge. You can see that's very specific. It's got a time frame set for it, or a date, and then it's also got a measurement of 50% so that they can look at how they're working towards that. Another one here is 95% of patients with an active OUD will have a THN kit. So again, this is fairly specific. It doesn't have a date to it, but you can easily add that in there. Yeah, I mean, I guess it depends on your local setting on how realistic that is, but it has a specific focus. And this other one here is ensuring that 95% of total active referrals are contacted, phone, email, text, in person within 3 business days effective immediately. So quite specific, quite timely, and quite eager to make that happen right away. So not sure how realistic it was, but it sounds like the effort here is to start this right away and work towards that 95%.
And for that one, I don't know, that maybe it's not quite an aim statement. Maybe it seems more like a decision, right?
Yeah.
Effective immediately.
Yeah.
So
yeah, it could
we'll
be
workshop that one a bit. Yeah.
Yeah, you could rephrase that 95% of total active referrals will be contacted within X amount of time. So I know we don't have a lot of time, I think just a few minutes, but just a reminder, this was the handout that was emailed out. I know it didn't work on Zoom, but this is just, an outline of what we are looking for you to put together for your aim statement. Reach out if you need any support with this. We're happy to help. And then with the reports that are due on the 4th of July, we're looking to have you submit that aim statement so that we can have that in there and ready for you guys to start moving ahead with the work. Just a reminder, this is our timeline. Not a very long timeline. I recognize that, but we'll make sure that we provide all the supports and resources needed to be successful over the next 10 months. Our next, a few reminders here is that our next webinar is going to be July 19th from 8 to 9 a.m. I know that this time was suggested, and please feel free to put this in the feedback in the chat or in the evaluation if this time it doesn't work for everyone. I know at 7:59 this morning, Angie and I wondered what we would do if no one showed up, and we just weren't sure if this was the right time. So do let us know. We're happy to adjust. Start meeting regularly with your team. Set those dedicated meetings, every week if you can, even just for 30 minutes or every 2 weeks. We'll connect you with Kelsey, who is happy to support you in getting that going. We'll send over the login details for the team monthly reports, and just keep in mind that the first report is due actually the 4th, not the 1st, because that is a holiday. And then our next full learning session event is September 22nd, 9 to 3 over Zoom. And don't forget, you have the listserv here to connect with the wider community here if there's any questions or discussions you want to have. Also a reminder, if you haven't submitted your team LOU, physician LOU, team roster, send that in as soon as you can. Take some time to review the prep manual. And just again, remember, this is a big big goal we're working towards, but just start small and, small steps towards that bigger picture. And thanks again to all of our supporters and funders that are making this possible. And if you need to reach us, you can reach us at boostcollaborative@bccfe.ca. And thank you to all of you for joining us today. I know it's not easy to take time away to do this, but we really appreciate you guys being here. And we're very much looking forward to the next 10 months together to support you guys and to support each other with this work.